Welcome, everybody. We're so excited to see you all joining us today. We're going to start in just a minute, but welcome. If you want to chat in your name, we're going to ask you in a second, why is vaccination important to you? So go ahead and think about your answer and jump in and put that in the chat for us. Why are you here today? What all are you hoping to get in terms of information? And we have some terrific presenters. I know you're going to really enjoy today's session. So we really appreciate you joining us today. And happy December to everyone already. Hard to believe we're fast approaching a new year. So welcome again. Glad that you're here. We will start right on the hour, which I have is right now. So again, welcome. We're excited to have a wonderful presentation. Some terrific folks sharing today. And so want to welcome you to our RSV Prevention Summit, Practical Strategies and Expert Advice for Expectant Moms. My name is Brenda Barker, and I am the TIPQC Executive Director, and we are honored to host our colleagues from Vanderbilt as well as from the state on this webinar today. So as I mentioned, we're going to ask you, why is vaccination important to you? And really, hopefully we'll see some great answers. Be sure and put your name there as well. But why is it important? Is there something as well that you're really hoping to hear throughout the day today? And I'm going to ask Anastasia if we have some of those pop up, if you can tell us why folks are saying vaccination is important to them. What are you seeing in the chat, Anastasia?
None yet. I think people are still thinking about their answers.
Super great. Hopefully we'll see some of those pop in. We're going to wait just a minute. We'll pause and give you a second to think. Maybe take a deep breath. You've run from another meeting, and so we are so grateful that you've joined us. And as you're popping in, I do see more people joining us. We're just asking you to tell us, why is vaccination important to you? Might be to a family member. It might be to some of your patients that you have seen in the past. What a vaccine could have done, or what it did do as well in prevention. So give you another minute to keep thinking on that. Do we have anything in the chat yet, Anastasia? I'll give you another.
Not yet, but I see Dr. Thompson is typing.
Okay, good. We're going to get one.
She said, helps reduce the risk of severe infection and complications from disease.
Wonderful. Absolutely.
And Ashley Henderson said, as a former PICU nurse, I've seen the impact of several illnesses on kiddos firsthand. Now, as a mom of 2 under 3, I know prevention is so important and takes a collective effort.
Thank you so much. Absolutely. And fun time for you with 2 kids under 3. So appreciate you joining us today. All right. Y'all keep chatting those in. We'd love to see your experience and what you bring to today's webinar as well. Well, as I mentioned, this is our RSV Prevention Summit, looking at practical strategies and expert advice for expectant moms. As I said, my name is Brenda Barker, and we are happy to host this with our colleagues from Vanderbilt, and Tara Nielsen will be taking over as our moderator and sharing her perspective as well. We'll look at some stats from the state, and then we're going to have a physician MFM perspective. We'll look at how to talk to our patients, the patient and doula perspective, and then the pediatric perspective, as well as where can you get more information. And as you can see, we have a wonderful lineup of speakers that will be introduced right as they're sharing, and hopefully you'll feel free to use that chat box to go ahead and ask questions as they are sharing. So you don't forget them, but also we can be sure to ask those questions as we go along. It's my privilege to introduce Tara Nielsen, who is a physician at Vanderbilt University Medical Center and the host for today. Tara, I'm going to turn it over to you.
Thank you, Brenda, and thank you, TIPQC, for just putting together this webinar for us and helping us out and protecting our moms and babies across the state. So I have had the honor and privilege of serving women through Middle Tennessee, through the lifespan around Middle Tennessee. But it is with great joy that I get to practice general obstetric or general. I'm a general OB, and I get to care for women as they become moms and their families grow. And so in light of recently having Thanksgiving, it was extra special this year in my family because last year my nephew was actually in the hospital with RSV as a baby, and so we couldn't all be together. But this year we were able to be together. So as a OB and as a mother and as an auntie, I feel like this is a really important topic, and anything we can do to keep our moms and babes safe is important to me. So we have the honor and privilege of having Sarah Winders with us today. She is an epidemiologist for the Tennessee Department of Health, and she is going to give us a little bit of a background on RSV numbers within Tennessee. Sarah, thanks for joining us today.
Hi, yeah, thanks so much for having me. I'm happy to be here. So I'm excited to maybe kind of set the stage for the conversation following me. As a disease surveillance epidemiologist, I am really passionate about data in general, and also using that to kind of show the burden and where to focus all of our efforts. So I'm hopefully going to kind of introduce you to some of the impact that we see here in Tennessee that RSV has. Next slide. So to start, I think I really want to set the ground on really what decades of research have kind of already established about RSV, because the patterns that we see here in Tennessee are in line with what we've had documented more broadly. RSV is incredibly common, especially in early childhood. By the time infants reach their first birthday, about 2/3 or 68% have already been infected at least once. And by the age of 2, that number climbs to 97%. So almost every child encounters RSV early in life. Next, thanks. For most people, infections are mild, but because infants have such tiny airways and limited reserve, RSV can cause severe lower respiratory tract disease in this age group. And about 1 to 3% of all children under 1 are hospitalized each year because of RSV. So setting the foundation or framework here, let's next look at Tennessee's data specifically. This slide shows what RSV looks like in Tennessee using our emergency department data. And the bars represent monthly ED visits with an RSV-related discharge diagnosis from January 22 through November 25. The colors correspond to different age groups here. And so what stands out immediately is the orange bars are children 0 to 4 years of age. And so while older children and adults obviously do get RSV as well, the vast majority of our ED visits we see here are among children under 5. Next. In this next slide, we're looking at percentages, a weekly percentage of all ED visits in Tennessee that had an RSV-related diagnosis, again, broken out by age group, just for this past year. And again, that orange line, our 0 to 4-year-old children, you can see how much that they hit and sit higher compared to our other age groups throughout the entire season. And so what's most striking is really what happens during peak weeks, that more than 1 in every 10 ED visits among children under 5 were for RSV. Next. This last slide that I want to share with you, I'm actually going to walk through kind of in a 3-part series so that we can really drill down to our youngest age categories here. We're looking at weekly RSV-associated hospitalization rates in Tennessee over the past 7 seasons, and our y-axis is going to stay the same for all 3 figures in this series, but we're starting here with our broadest pediatric age groups, are 0 through 4, 5 through 11, and 12 through 17 years of age. Initial impression is pretty clear. Our younger age group tends to show higher hospitalization rates. But next, we're going to break down that 0 to 4-year-old age group even further. Next. So we're zooming into that 0 to 4 age group, breaking it down further into 0 to 1 year, 1 to 2 years, and 2 through 4 years. Again, the younger age groups, even among this subgrouping, show higher hospitalization rates. But we're going to do that one more time and break down just those under 1 year of age. And so now with our two youngest age groups, 0 to 6 months and 6 to 12 months, the takeaway is really clear here. Our youngest infants under 6 months of age have the highest hospitalization rate of any pediatric group. And so this level of detail that we've driven down to now really emphasizes why public health and clinical prevention efforts target both maternal vaccination and infant interventions, because the goal is really to protect those at greatest risk in this critical period. And so my last slide here, I don't know if I'd be a good disease surveillance epi if I didn't give a quick plug to how we monitor RSV outcomes in Tennessee. RSV-associated pediatric deaths did become reportable in our state as of January 1, 2024. So while individual cases of RSV are not reportable, this mortality reporting does allow us to systematically now track the most serious outcomes and understand where that burden is the highest. So when providers like yourself report, it really helps us in public health identify who's most at risk, and also directly informs the prevention approaches like maternal vaccination and infant antibodies that I think my colleagues will be highlighting next. So thanks so much.
Thank you, Sarah. Next, I'd like to introduce Dr. Jen Thompson. She is a maternal fetal medicine physician here in Middle Tennessee, and she also serves on an executive committee for the ID, so Infectious Disease Society for OBGYNs. So she is definitely a leading authority on all things moms and high-risk moms, as well as vaccination in pregnancy. So Jen, why is RSV prevention important to you?
First of all, thank you so much for having me today. It's a pleasure to be here. As we've already heard from Sarah, RSV clearly has a wide impact on our littlest members of society. And the last few years, it's been so exciting to now have products available both for maternal vaccination as well as newborn products to help reduce this severity of hospitalization and severe illness associated with RSV. And I think that it's just amazing that we've had this opportunity in the last couple of years to have something that helps reduce this risk of severe disease and help, hopefully, for families that have been impacted by this before, not having to have other families go through this. So it's really important to have vaccines available.
So many pregnant patients worry about anything new. How do we reassure them that this is a safe option?
Absolutely. Let's go to the next slide. Both in the initial trials that were done and since the RSV vaccine has been released, there have been several studies that have shown there are no safety concerns for most maternal and infant outcomes associated with the RSV vaccine. When we get a vaccine, oftentimes we have an immune reaction, which most commonly is mild and has pain at like the injection site, sometimes muscle aches and pains and headaches. Sometimes we get nausea. That most often is just the activation of our immune system, and that has been the most common reactions that have been reported associated with the RSV vaccine. There have been large randomized controlled trials that have showed no significant association between the RSV pre-F or the Abrysvo, which is the specific vaccine that we give moms in pregnancy, and hypertensive disorders, stillbirth, birth differences, placental abruption, or babies that are smaller than what we would expect. There was some initial concerns regarding increased risk of preterm birth, but studies that have been done have shown over the last since the RSV vaccine became available here in the United States that have shown no significant increase in that preterm birth rate when the vaccine is administered between 32 and 36 weeks, and that the preterm birth rate that we see in 2023 and the 2024 season, that preterm birth rate was similar among what we would expect in general, around 4%. And so we have not seen any kind of safety signals or concerns associated with the vaccine.
That's really great. Can you explain a little bit more on how baby is protected through mom getting the vaccine or maternal immunization?
Sure. Let's go to the next slide. When mom gets a vaccine, as I just mentioned, mom's immune system starts to activate and makes antibodies against the RSV virus. These antibodies then are able to cross the placenta and they enter into baby's bloodstream. It takes about 2 weeks for these antibodies to be developed and to cross the placenta to provide that protection for baby, which is one of the reasons that we recommend the vaccine at least 2 weeks before delivery. And then when baby is born, they will have enough antibodies in their blood to help protect them against the RSV vaccine for at least the first 6 months of life.
That is great. Is there anything else you'd like us to know?
Yeah, I think the last thing to share is just how efficacious the vaccine is. In these initial studies, this vaccine showed an 80% reduction in the risk of severe or hospital-attended RSV in the first 3 months of life, and a 67% reduction during the first 6 months after birth. And so a very effective vaccine to help protect baby from that RSV virus. And so definitely something that I talk to my patients about and recommend getting the vaccine when they're eligible.
Awesome. Thank you so much. It's neat because I think if I'm remembering right, Sarah's slide showed that about 68% of babies 0 to 6 months are exposed to RSV or clinically have RSV. And so a 67% reduction is fantastic.
Absolutely.
Thank you for sharing. Next, I'm really excited to welcome Bethany Sanders. She is a midwife here in Middle Tennessee, and I love working closely with Bethany. She also is just really great at counseling patients but yet respecting patient autonomy. So, Bethany, I guess I just wanted to give you a chance to introduce yourself as well as share why RSV prevention is important to you.
Thank you, Tara, and thank you for the opportunity to participate. I think vaccines have been in the news a lot recently, and so it's excellent to have an opportunity to provide information about one of the newer vaccines to people who are in the community, as well as working with pregnant and expectant families. My name is Bethany. I am a certified nurse midwife in Middle Tennessee and have been since 2013. I'm also a parent, and I remember as when I was pregnant, being counseled about vaccines and having that fear, but also having a fear of having a sick child. And then, as a parent, when you're taking your child for their routine pediatric visits and they're receiving vaccines, knowing that it was hard, but knowing that the disease would be inevitably way worse than the child receiving the vaccine. So I see a lot of patients in the office and do a lot of counseling, as well as have an opportunity to hear some of the concerns that patients have directly from them.
So midwives are often a trusted source of information. What practical strategies do you use during prenatal visits to introduce RSV vaccination or prevention?
Yes. So I like to start talking about RSV or very early on in pregnancy, including as early as at the first visit. I think there's an opportunity when we're talking about the pregnant person's due date to go ahead and sort of put that plug in of, oh, I see that your baby is going to be due during RSV season. One of the things that we'll discuss more and recommend is that you receive an RSV vaccine, so that that idea is already planted, that that's part of our routine prenatal care. As we move into third trimester, a lot of times I'll assign it kind of the topic as like a homework of, at the next visit, that will be when you'll be in that window of 32 to 36 weeks when we recommend vaccination. And because I want families to feel like they have an opportunity to research it, to ask questions, to discuss it among themselves in a non-pressured environment, so that they don't feel like they have to immediately, at that visit, say yes or no as to whether they want to do it. We care for a lot of vaccine hesitant families. And so I'd like to also introduce the topic early, so I have an opportunity to kind of feel out what their thoughts are and where there may be opportunities to provide information, or to, again, not to pressure them, but to get an idea of if they're open to a change of heart, particularly about RSV. I usually will start that conversation by saying, what are your thoughts about that? Or something very open-ended and non-judgmental. And if they immediately kind of shut it down by being like, we don't vaccinate, I'm not interested in that, you can follow that up with may I ask what your concerns are? And that, again, gives them the opportunity to, if they don't want to continue the conversation, to kind of move on, or to let me know, are there places where they've received some misinformation in the past, and I may be able to kind of correct any misinformation, but in a way that's very non-threatening. While we recommend RSV vaccination for all eligible pregnant patients, I think there's also strategies to make what's a public health recommendation, kind of at the 10,000-foot view, personal to the individual, by looking, if this is someone who has younger children, sometimes approaching it from your other children may have, as we've heard, they probably have had RSV, and so you may be familiar with this virus. They may attend daycare, so that may be an opportunity to kind of say, oh, and once the new baby's here, the other kids may be bringing germs home, because any parent that has sent a child to daycare or church nursery or school is familiar with how quick some of viral illnesses can be spread. Sometimes I'll take an approach of looking at if the pregnant patient is working outside the home, what her contact with the public may be, and how she may be familiar with how people are not great about isolating themselves when they're sick, and using that as a way to kind of personalize our recommendation for protecting herself as well as her baby. And the last thing I think is important is kind of drawing a picture of what RSV infection looks like in infants, because people may not be familiar with it as they are with other childhood vaccine preventable illnesses. And so just kind of drawing attention to the fact that, they can have a lot of secretions and they can have difficulty breathing, and just really highlighting that it's that it is a respiratory illness, and how with newborns, being particularly susceptible, what that potentially would look like. I think it's hard. Most parents would rather themselves experience discomfort than their child, as they have that protective instinct. So we kind of, finding a way, again, that's not fear driven, but a way to appeal to that.
I love that. I love that you're using, individual examples to communicate, to your patients what the importance. How do you include partners and family members in that conversation?
I think part of that is making sure that they feel included by just even acknowledging, recognizing when they're able to be there as part of the visit. The same way about making it personal including the partner as part of that discussion of what their risk factors may be and how they may be a transmitter of illness, but also asking them directly, what are your concerns? What questions do you have? And providing them with information as well, knowing that for a lot of family members, again, we want them to go home and to discuss it, and we want it to be a mutual decision where both partners, understand the importance of this and are on board with it. So just providing them that opportunity to make them, to let them know that they are an important part of the pregnant patient's decision making and appealing to them as well.
Thank you. Thank you, Bethany, for sharing your insight. Those are great pointers. I love your approach. Next, we have with us, thrilled to announce Andrea Hewitt. So Andrea is a doula here in Middle Tennessee, and she's also the owner of East Nashville Doulas. Thank you for joining us, Andrea. So as a doula, you are often a trusted source to patients. Can you give us some insight on what a doula is and how you are a trusted insight to patients, for patients?
Yeah, thanks so much for including us. We don't often get included on these sorts of webinars, and I think that's a missed opportunity. So I really appreciate you asking us to come, or asking me to come today. So I am a birth doula and been doing this work for about 10 years. And I also own East Nashville Doulas, and we have about 30 doulas working with us. And I think the first question when you talk about, what a doula does, I think that's always the first point of info for people who are not familiar, is they have an idea, but they don't know what we are. And so I like to always start by explaining that we are non-medical labor support professionals. But in addition to the labor support, we're also seeing folks in pregnancy, because people sometimes will hire us right after they become pregnant. And the way we become a trusted resource for them is, first of all, they see us as working for them, right? So they see us as their personal support person. And they're going to spend a lot of time with us. I know that especially if someone has midwifery care, they might have longer appointments, but sometimes with doctors and OBs, they may not have a lot of time. We spend at least, this is at least 4 hours, 2 separate meetings with them. And usually those 2 meetings are 2 hours each. So that's a lot of time that we have to build relationships, build trust, and then also provide great evidence-based information. Our doula agency is committed to that. I tell people I like for everyone to know we're the education doulas, and we're always trying to stay up to date on all of the recommendations, not just for vaccines, but other evidence-based information. So I'm always, encouraging the doulas that work for me to stay up to date so that they can then provide that good, brand new evidence-based information to our clients as well, because they do look to us. And many times I've seen it in my own, experience, where even in the middle of birth, they'll look to the doula to say, what should I do? And while it's not our place to tell them what to do, they just automatically have, we're now their trusted resource. And so I think it's really important to get doulas this good evidence-based information so we can get it to our clients.
That's awesome. So I think as a doula, you probably often hear worries that patients are afraid to bring up to their OBs or their midwives. What RSV related, or any other vaccine for that matter, myths do you commonly hear?
Yeah, I think like the other presenters were talking about RSV, the RSV vaccine seems to be new. And so we haven't heard a whole lot about it specifically, but some of the challenges that especially Bethany mentioned, right, about people who are vaccine hesitant or, vaccine refusing, people who think, well, okay, I know these vaccines because I've heard of them and I've had them, or I had them as a child, but this new one, why do I have to have another vaccine? So when I talked with my doulas and asked them what they're hearing on the ground, that's what they kept telling me, was that people were just like, explain to me why I have to have one more vaccine. It just seems like it's the number of them that people are kind of hesitant about. Not always. I mean, we have a lot of clients who are like, they understand it. They've got the information from their doctors and they're on board. But the hesitancy, I think, is around the number of vaccines and just helping them to understand why one more.
So that's great. That's great for me to know too, just as a obstetrician here in town, is that it's a reason we space out our vaccines too. And different, specifically the RSV vaccine is from the months of September to January, and we want to from 32 to 36 weeks. And the reason for that is so that we, can get that immunity on board before they deliver, but not too soon either. So they have enough coverage through the entire season. So that's great.
Yeah.
That's a great point. So how do you handle situations where a family is getting mixed messages from social media or community circles?
Gosh, I wish I could, like, there was a switch I could switch off social media while someone is pregnant. It's there are definitely some pros, but also some cons. I think what we do is from the very beginning, our first contact with clients, we really and truly encourage them to try and not go to Dr. Google for all of their questions. I know we all do that, and it feels like so simple and easy, but there's just so much misinformation. So we really try to teach our clients through our meetings, our prenatal meetings that we have with them, is really consider the source, right? So really think through, where are you getting this information? Where is the source? Again, we're fans of evidence-based information. So, if there is information out there, let's test it. Let's figure out, where did it come from? Consider the source. And then, if you do find some information that's out there somewhere on social media and you have a question about it, go to your doula, go to a doctor, ask somebody who you trust to verify this information, and not just accept everything that social media says as this is truth, right? So we really try to encourage our clients to become good consumers of information. And this is across the board, whether it's about birth, whether it's about vaccines, whether it's about, what to expect with your newborn. There are so many unrealistic expectations of newborns out there that we see, because of social media. And we really work very hard to educate people. So I would say our tools are education and helping our clients to become better consumers of information.
Awesome. Thank you so much, Andrea.
Yeah.
It was great to have you and hear what a doula how you can support pregnant women. Next, we have Dr. Kate Carlson. She is a pediatrician here in Middle Tennessee and here at Vanderbilt Monroe Children's Hospital. And so, Dr. Carlson, why is RSV vaccination important to you?
You all have already made this point. I just want to say that as a pediatrician, it is so wonderful to work with a community of professionals that I don't even work with necessarily on a daily basis that are already thinking about preventing RSV in very young infants. So it's for the very young infants for preventing hospitalization. So as you all know, RSV is a leading cause of hospitalization for young infants. As a pediatrician, I have, over the course of my career, starting very early in residency, taking care of infants that I've admitted 10 patients a night with RSV. And then we have babies who are intubated, babies who have to go on oscillators, babies who have gotten very, very sick with RSV. So anytime that we could prevent that, it's obviously what we want to do so that they don't have to go through that.
Could you just highlight a little bit on what are some of the risks that when a patient or a mom chooses not to vaccinate that maybe parents don't always realize?
Sure. So if a mom is not vaccinated with a Brisvo, she does not pass along the antibodies to her infant. And that child does not have the benefit of being protected against RSV in that season. So it's particularly important in the RSV season, like you talked about. You time yours September through January to be given at 32 to 36 weeks, because we see RSV between October and March typically for the RSV season. Now, the post-COVID respiratory virus seasons were very different. We have now seen RSV return to its standard seasonality. Starting last year, it has returned to really being that October through March. And so we protect kids during that time period. So if moms don't receive a Brisvo, then their infant actually can receive an injection of a preformed monoclonal antibody that protects them instead. And I can tell you a little more about that.
Yes, we'd love that. Can you share if a mom, chooses not to get vaccinated herself, or maybe she wasn't offered the vaccine or missed the window, whatever it may be, what are the options out there for babies?
Yeah, and we see a lot of these, particularly right now, in October and November, because they might have missed it. The getting vaccine, operationalized is a little bit more difficult in the beginning of the year. So, they can get the two options are Beyfortus or nirsevimab. Or there's a newer option that's called Enflonsia or clesrovimab. But both of those are effective for 5 months. They can be given between October and March, and that's when we offer it. At Vanderbilt, we're offering nirsevimab because it can be given both for standard risk patients, so the babies who are obviously all of them are at high risk, from 0 to 7 months of age, and also can be given for the high risk infants, so 8 months to 19 months of age, who are at higher risk. I just want to point out that this is also really important because you all are giving the Abrysvo vaccines very effectively, and we have a number of moms who actually received Abrysvo with their first pregnancy and are now on their second pregnancy. And so for those moms, for those infants, the only option is to get the nirsevimab, or in places where it's used, the clesrovimab.
And that's a good point. So currently, Abrysvo is only FDA approved for one-time use, and we know there's active research out there that may change in the future. But for right now, for those mamas that maybe received it in season 1 or season 2, they would not be a candidate to receive it again. So they do have the option of Beyfortus. Can you also speak to, this isn't, the monoclonal antibodies is not something that's new, right? This is something that maybe we've been giving for years for premature infants.
Yes,
Okay.
we were giving Synagis to our highest risk patients, but it only had a monthly half-life, and so we actually had to redose it monthly. It was, I can tell you, a scheduling nightmare. Those kids did not get effectively protected because to get them to come in, it was also extremely expensive. It was quite a bit more expensive overall. And so it is much more cost effective for us we can give this single dose and they're protected for 5 months. We are giving this vaccine to NICU, so to patients who are born less than 35 weeks, whose mothers did not get the opportunity to get RSV protection. Those infants actually receive the monoclonal antibody before they're discharged from the NICU. And then other children can't get it before they go home from the normal newborn nursery just because of some VFC, just some administration issues. But those infants can get the monoclonal antibody actually in their newborn visit. And we have quite a few infants that we do protect in that visit. The great news is that because it is not a standard immunization, it doesn't provoke an immunologic response, and there's no fever associated with it.
Okay, great. Thank you.
The kids tolerate it very well.
Awesome.
I just want to
go ahead.
I just want to point out that we have seen a significant reduction in hospitalization. So you all have talked about the Abrysvo data. The data with nirsevimab actually is as good, if not better. I'm not suggesting that there's any superiority of one over the other, but the hospital attended rates are more than 70, is around 78% reduction in medical attention. So you need to go either to the ED or their pediatrician, and there's between a 35 and 48% reduction in hospitalization.
Wow, that's great data. Thank you for sharing, and thank you for being here. I think it's so important, that, we recognize that, pregnancy and taking care of a family is a team approach, right? And so having the ability to have Andrea here and represent, the support side of things as well as the pediatric side of things is great. And we enjoyed having you, and thank you for sharing. Next up, I'd like to introduce Dr. Etoy Garrison. She is a maternal fetal medicine physician here in Middle Tennessee at Vanderbilt, and she not only serves patients individually for high-risk pregnancies, but she also is the director of community engagement and population health here at Vanderbilt. So, Dr. Garrison, what is the most important take-home message that you would want clinicians to share, or you would want patients to know?
Hi, hello, and thank you, Tara, for inviting me, and thank you, TIPQC, for hosting such a fantastic webinar. I've just been so inspired by all of the speakers, hearing their perspective about vaccine safety and the benefits of the vaccine for our moms. I see a lot of high-risk patients in my practice, but I always try to put myself in their shoes, and I always think about the challenges that they face. I think about the questions that they may have, and whether you're a high-risk mom or a low-risk mom, whenever I bring up the question of a vaccine and the topic of the vaccines that we have available, there are questions that patients have, and I always appreciate an opportunity to talk about those and to answer those questions for them. I think the one thing that I would want moms to know is that the vaccine is a safe and effective option at decreasing the risk of RSV for their baby. And I think often for patients, because there's so much debate in the news media, and there's so many in social media, there's so many questions over the years that have been asked about the safety of vaccines. From you've got news reports that will discuss this, you've got influencers that will discuss this, you've got our political leaders that will discuss it, and it's hard to know it's hard to think about where do you stand, and especially when you have such a beautiful newborn that will be here soon, right? Especially when you're expanding your family and you've got a young baby to protect. It's hard to know who to trust. And so I think I would want moms to know that the vaccine is a safe option. And I would want them to know that even though there's a lot of different thoughts and opinions about so many vaccines, when you look at the trusted authorities, the CDC, NIH, American College of OBGYNs, American College of Pediatrics, American College of Nurse Midwives, they all talk about the benefit of RSV vaccination for those women who deliver between 32 and 36 weeks during those months from September to January. They talk about the benefit of the vaccine at decreasing the risk of serious illness for their baby. So I try to point out that those benefits, and I always acknowledge the confusion because it's there for high-risk moms, for low-risk moms. If I were in their shoes, I would be confused as well. So I think having that open and honest conversation with their primary obstetrician is key, with their primary care provider is key, with their doula is key, with their midwife is key, so that the patient can get as much information as possible and make an educated decision. On this slide, I really tried to think about, in an ideal world, what would be the best way to broach the conversation with a patient? And as our wonderful midwife Bethany has already stated, kind of having some anticipatory guidance in the first trimester is key, where you can really talk about the benefit of all of the vaccines that we offer in pregnancy. But really, it's an opportunity to have the patient ask questions and to get their initial thoughts if they're willing to share. Often, I think that patients will fall into three buckets. You have patients who haven't received vaccines in the past for one reason or another and are not interested, which is totally okay and understandable. And then you have patients who are open, who want to have further discussion. Some women have already made up their mind and are not have other questions that they want to talk about and things that they want to discuss. But others are kind of in that, maybe I've heard about this a little bit, let's talk about it. And then you have your group that are absolutely, yes, I've received vaccines. I know how beneficial they are. And if it's recommended, it will be helpful for my baby. Yes, yes, yes. And so really that initial conversation is one to really explore with the patient their thoughts about vaccines and to identify if they're open to having a further conversation and to let them know which ones we would routinely recommend. In the middle of the pregnancy, 20 to 24 weeks, it's a great time for a follow-up discussion. And we can give the patient a roadmap of when we would normally recommend vaccines. And 28 weeks, the Tdap vaccine is recommended for all patients to decrease that risk of whooping cough. We might discuss the RhoGAM antibody if the patient is Rh negative. But the 28-week mark is like a red flag for every obstetric provider because we want to make sure that if there's an opportunity to prevent whooping cough, we offer the vaccine. But then at that point, it's another time to revisit that conversation and say, 4 weeks from now, you'll be within the window in which the RSV vaccine is going to be beneficial for your baby to decrease the risk of RSV and be helpful. I like the idea of assigning homework. If the patient is interested, we can ask the patient to look into it if she has questions, and we can give her trusted resources to go to. And then 32 to 36 weeks is when we would talk about and offer the vaccine directly. Next slide.
Thank you, Dr. Garrison. You did such a great job of explaining the significance from a population health standpoint, but bringing it down to the individual, which is, something I think you do a great job. And I always tell patients too, I say it's my job to give you all the information and to know what to expect, but I also really want you to have enough information to feel like you're making a good decision, right? And a decision that you feel comfortable with and is best for you and your baby. So I think that's great. We all want to protect moms and babies. Where can moms and babies parents turn to get trusted information if they want more information beyond this webinar or beyond the conversation that they're having with their prenatal provider?
Absolutely. So on this slide, I've listed a few resources for you. American College of OBGYN has a great infographic that discusses the benefits of the RSV vaccine. And they actually have several. So there are images of both with QR codes and links. And after the webinar, I'll share all of the links with TIPQC so that they can be posted on the website. On the next page, there I have a few additional resources for you. So perfect. CDC. So this is one. Actually, when I prepared for this webinar, I wanted to go to all of the sites that where it would be trusted source of information, and I also wanted to look at the governmental sites to see if there's been any change, any additional update that moms and families would need to know about. And although there's a lot of discussion about the COVID vaccine and the flu vaccine, hepatitis B. I think there's a comment in the chat about a new recommendation from the CDC for hepatitis B. The recommendation for RSV during pregnancy has not changed. and this is from the CDC website. I should have put a date on when I obtained the screenshot, but this was just last week, and I actually looked again this morning, and I don't think there's been any change or any discussion about it. They're just agreement that this vaccination is helpful at decreasing the risk of RSV. So this is a screenshot that will take you to the website, and we'll also have the link for you there. And then when you go to the next slide, Society for Maternal Fetal Medicine, and there's a video. So there's another link there. What's interesting about the videos from our national organizations is that they have some site visits recorded that you can see. And this is a great video by SMFM that was produced December of this year, 607, no, sorry, it was produced in 2024, and it only has 607 views. But if you go to the next slide, I actually took screenshots of so much information online about the RSV vaccine and benefits, and you can see all of the views. So it just kind of points to the fact that we get our information from so many different sources. Friends and family, certainly, but then, we all have our phones with us, and I'm guilty of looking at social media for information just as much as everybody else. So there, you could see the number of views for the various influencers or news articles where they online, and you can see how visited these sites are. Just additional sources of information that we all have at our disposal. And so for the next slide, you'll see the American College of Pediatrics has actually done a great job of developing a really, really patient-friendly source of information. Healthychildren.org is a great place to look for information about so many things. And as an obstetrician, I was not aware that this site exists, but I think it is fantastic. So there's a QR code and a link that we will I'll share with TIPQC so that it'll be on the web page. And if you go to the next slide, they have a list of people with Instagram, Facebook, YouTube videos, all of the list of trusted clinicians who can also give you additional information about so many things related to the care of babies and young children, and RSV vaccination and the monoclonal antibody. I'm sure our list would be listed there. But I think for people who are looking for advice and looking and kind of developing that list of questions for their primary obstetrician, these are sources that you could go to that will help you populate your list of questions. And I think that is it for me. Oh, this is another list of resources with links. So you'll have all of this available to you as our patients do their homework. And I think our key as obstetric clinicians is to really think about how can we make these links easily available to our patients.
Wow, very thorough. Thank you so much, especially even touching on the social media aspect of it, because we know, as you said, a lot of patients obtain information that way. So I guess if we're going to use social media, right, let's direct people to reputable sources within social media. So thank you. Now's the time if anybody has any questions, if they could put them in the chat.
It looks like Dr. Garrison had a question. She said, can you comment on the timing of the monoclonal antibody administration for moms who may decline the vaccine?
Dr. Carlson, this is probably right up your alley.
Yeah, probably. So it can be given to the baby anytime actually from birth, although we have very few birthing hospitals in Tennessee that are offering this. But from the first visit up through 7 months and 30 days or 29 days. Once they hit 8 months, they can no longer receive it, but it is best for them to receive it as soon as possible when the RSV season starts. Some patients choose, we have some very on top of it, some parents who really want to get their baby that protection as soon as possible, who will choose to come in and get that as soon as the monoclonal antibody becomes available in the fall. But otherwise, we have a catch-up series that we will give it to them. So we see babies typically at a 2 to 3 day check, a 2-week check. For those that qualify, a 4-week check, and then a 2-month check, and we can get them that antibody anytime during that period of time. Otherwise, at their 2, 4, or 6-month standard infant immunization. Infant checkups when we give them other immunizations. I will point out one thing on this, which is we offer this for any infant for whom they are unsure if the mother received the RSV vaccine or not. And the one thing that we run into with moms is that many times they don't know. They know that they got a vaccine, they know that they got a couple of vaccines, but there's 4 different injections that they could have gotten. There's influenza, Tdap, Brogam, and Abrysvo. And so knowing which one of those they got, we really want to get the infant the protection as soon as possible. And so typically, depending on where we are in the RSV season, we will either wait for the mom to find out, or because it's so difficult to get records, we'll just go ahead and give the infant the monoclonal antibody. There's certainly no negative impact, no adverse events from that, other than the fact that there's some additional cost to it.
Dr. Garrison?
I think that's such a great point for moms that receive the vaccine during pregnancy, and perhaps their pediatrician is not in the same medical system, as their obstetrician. And so then how do you remember that you received the vaccine? And I just wonder if you have heard of any kind of innovative ways of any of the panelists have heard of any innovative ways of making sure that the patient has a reminder. I don't know if there's, for some vaccines, you'll get a card that kind of lists the date and time of the vaccine. But I just wonder what is one good way to help moms remember that they received it?
Dr. Thompson, do you have any suggestions?
No, I was going to say sometimes the card can be really helpful. Pardon me. I think also just making sure that you're having like a clear discussion with your patients about what it is that they're getting that day. But as was mentioned, sometimes patients get a lot of different vaccines in the same day, but just I think having that conversation with them again about these are kind of all the vaccines. And I usually, for education materials, will sometimes send my patients like a message with just like some education in there through their MyChart. And so maybe it would be helpful if we send them like a message about like, here's your vaccine that you received today, so they could always pull that up.
Mm-hmm. And within Vanderbilt, within eStar, you guys do a great job of documenting it. And then our health IT group it actually follows all the way through, including, you guys have probably seen onto the newborns, onto the newborns, both admission history and physical and their discharge summary. That information is on there. We usually run into it when they've gone to an external OB system. So I think I'm seeing what a lot of our what our community pediatricians are seeing. I think the other thing is that, this is more in our families who speak other languages or have low health literacy. And so I agree with you. Like, what are the things that we do for those families to help them know? Because I think this protects your baby against a respiratory virus that maybe could be phrasing that they could remember, but pertussis equally is not a virus, it's a bacteria, but families just kind of know it protects their baby against respiratory issues.
And I think Bethany can probably agree with this too, that we're clinicians, but we're also educators, right? And so we are providing this information and making recommendations, but we need to do a good job of, speaking to their level of health literacy so that they can understand, their options and what they're receiving and what they have received, and go from there. Well, sadly, we're getting close to the end of our time here on this webinar. So there was a few announcements from TIPQC that I wanted to make sure that we covered. If we could go to the next slide.
And I'll jump in. What a fascinating conversation. And I would say have them take a picture with their cell phone because they have their cell phones with them. So if there's any material they can take a picture of and it have a date on that, that would be great as well. Well, we do have another webinar coming up on January the 12th, covering the same type of information with Dr. Betty Creech, looking more at the pediatric aspect of infectious diseases. We have an annual meeting that we host every year. This is going to be the evening of March the 24th, and we will have a film premiere on AFE, as well as the 25th, a panel discussion, and the 26th through noon will continue, but really spotlight that AFE conversation. And coming soon, we will have a podcast with these same presenters, and so I know you might want to share that. Feel free to jump in and listen to any of the podcasts that are there or make recommendations as well. And we'd like to know your thoughts on today's webinar. So please feel free to scan that, give us suggestions, what you liked, if you have other questions, and we'll make sure that our presenters got those. I think we have a few seconds left, probably. We just appreciate your time so much for joining us. We can stay on for a few more minutes if you have additional questions of our panelists, but I want to thank our panelists so much. Dr. Nielsen, thank you for moderating today. It's been wonderful to be with all of you and wishing everybody a happy new year coming up. I'll turn it back to you, Dr. Nielsen, if there's any additional questions for today.
Thank you, everyone, for joining us and taking the time. And we, again, want to thank TIPQC for keeping moms and babies healthy and helping us put on this presentation today. Any other questions, thoughts, last-minute wrap-ups? All right. Well, we hope you can join us for a podcast in the future. Thank you.
Thank you, everybody.